Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 236 of our pharmacotherapy series, which majors in antibiotic surgical prophylaxis. The next question reads, PLG, a 28-year-old man with a history of rheumatic heart disease, has a 12-year history of a heart murmur consistent with mild mitral stenosis and mitral regurgitation. During the past 4 months his murmur has become much more prominent. In addition, he has experienced severe dyspnea with light physical activity and 3+ pitting edema over both lower legs. Physical examination is notable for coarse rales and an S3 gallop. For the past 6 weeks, he has been maintained on digoxin and diuretics without significant relief of his shortness of breath. The cardiothoracic surgeon recommends mitral valve replacement and orders the following surgical antibiotic prophylaxis regimen: cefazolin 1 gram IV preoperatively, then every 8 hours for 24 hours. Is cefazolin the most appropriate antimicrobial for PLG? Why was prophylaxis ordered for only 24 hours? Although the incidence of postoperative wound infection for cardiothoracic procedures is low, that is below 5%, the devastating consequences of a postoperative endocarditis after valve replacement and mediastinitis or sternal osteomyelitis after sternotomy warrant antimicrobial prophylaxis. Common pathogens associated with cardiothoracic surgery include Staphylococcus aureus and Staphylococcus epidermidis, particularly with hardware placement based on these potential pathogens. Successful prophylactic regimens include cefazolin and cefuroxime. When cefazolin has been compared with cefuroxime or cefamandol, a statistical trend in favor of the second-generation cephalosporins has been noted, and collective wound infection rates were slightly higher in the cefazolin group. In contrast, a comparison of prophylactic cefazolin and cefuroxime in patients having open heart surgery noted a significantly greater incidence of sternal wound infection and mediastinitis in the cefuroxime group. Other studies similarly have not observed improved efficacy with cefuroxime compared with cefazolin. In conclusion, cefazolin probably is at least as effective as second-generation cephalosporins. Therefore, the choice of agent should be based on an institution's antimicrobial susceptibility and cost data. Hospital-specific antimicrobial resistance patterns are especially important in determining the incidence of methicillin-resistant Staphylococcus aureus (MRSA) or methicillin-resistant Staphylococcus epidermidis (MRSE) surgical site infection rates. Although vancomycin has not been determined to be superior to cefazolin, vancomycin is the drug of choice for prophylaxis in patients colonized with MRSA. Patients are at higher risk of MRSA carriage if they are frequently hospitalized or have a prolonged hospital stay, are exposed to broad-spectrum antibiotics, are known for comorbid conditions, or have severe underlying illness. The population to be screened for MRSA carriage and undergo decolonization with mepiosin is still being debated but is mostly considered for patients undergoing an orthopedic or cardiac procedure. Surveillance of susceptibility of Staphylococcus aureus isolated from surgical site infections should be done if mepiosin is used for decolonization. Meta-analyses reveal no differences between first and second generation cephalosporins or between beta-lactams and glycopeptides in the prevention of surgical wound infection. Thus, the cefazolin prophylaxis selected for PLG is acceptable, provided the patient is not colonized with MRSA or MRSE. Additional empiric coverage with an aminoglycoside, a fluoroquinolone, or asteronym may be considered when gram-negative pathogens are a concern according to local epidemiology and risk factors including hospital admission greater than 48 hours before surgery, diabetes mellitus, and ventilator dependency. With regard to duration, the shortest effective prophylactic course of antibiotics should be used, i.e., single dose preoperatively or not more than 24 hours postoperatively for most procedures. Postoperative doses after wound closure are usually not required and may increase the risk of resistance. Single-dose prophylaxis, a viable option for many surgical procedures, is still being evaluated for cardiac procedures. In practice, cardiothoracic antimicrobial prophylaxis often is continued up to 24 hours after surgery. As in PLG, no benefit is seen to prolonging prophylaxis to more than 24 hours, and such use should be discouraged. The duration of antimicrobial prophylaxis ordered for PLG is appropriate. The next question reads, S.G.J., a 27-year-old woman, is admitted to the obstetrics unit at term with her first pregnancy. She is scheduled for a cesarean section because the baby is in a breech presentation. Cefazolin 1 gram IV to be administered after the cord is clamped and every 8 hours for 24 hours is ordered. So my question to you reads, is this surgical prophylaxis appropriate or inappropriate? As noted previously, the shortest effective duration of prophylaxis should be used. In the past, 1 to 5 day antimicrobial regimens were commonly used for caesarean section, but single-dose regimens have been proven to be as effective as these longer regimens. Ferro and colleagues demonstrated that a single 2 grams dose of cefazolin was superior to either a single 1 gram dose or a 3-dose, 1 gram prophylactic regimen. Others have noted similar results, i.e., a single cefazolin dose administered after the umbilical cord is clamped is sufficient in preventing postoperative wound infections in caesarean section. Single-dose prophylaxis is less costly and minimizes the development of bacterial resistance. Antibiotic prophylaxis has traditionally been administered after clamping of the umbilical cord to minimize infant drug exposure. This early exposure could theoretically mask the signs of neonatal sepsis and favor the acquisition of resistant organisms. However, administration before initial incision and cord clamping decreases the incidence of maternal infections without adverse consequences to the child. Thus, S.G.J. should receive a single 2 grams dose of cefazolin before incision, without the 3 additional doses. Single-dose prophylaxis has been found to be effective in a variety of GI tract, orthopedic, and gynecologic procedures. A single dose of an antibiotic with a short half-life, however, may provide insufficient antimicrobial coverage during a prolonged surgical procedure. Repeated intraoperative dosing or selection of an agent with a longer half-life is recommended when the duration of surgery is long to maintain adequate tissue concentrations throughout the procedure. The next question reads, S.G.J. is discharged on the 5th hospital day and instructed to observe her incision site carefully for signs of infection. My questions to you are, what are the typical signs of site infection? What is the typical time course for signs of site infection to manifest? Most surgical site infections involve the incision site and are defined as either superficial, involving the skin and subcutaneous fat, or deep incisional, involving fascia and muscle. Typically, an infected incision site wound is red, warm, and purulent and sometimes swollen, tender, or painful. Poor wound healing or dehiscence, that is premature opening of the incision, is highly suggestive of infection. A surgical site infection can also involve any part of the anatomy, e.g., organs or spaces, other than the incision, which was opened or manipulated during an operation. The purulent drainage, if present, should be cultured to identify the causative pathogen and direct antimicrobial therapy. Empiric therapy directed against the most likely pathogens should be instituted while awaiting culture and sensitivity test results. Although most incision site infections are diagnosed shortly after surgery, within 30 days, some deep-seated infections present indolently during weeks to months, for example, abscess formation. Infection of surgically implanted prosthetic hardware may take place up to a year after the surgical procedure. The next question reads, K.L.T, a 46-year-old woman, has a recent history of abnormal uterine bleeding and vaginal discharge. Endometrial biopsy is positive for squamous cell carcinoma, however, there does not appear to be an invasive disease. The diagnosis is carcinoma in situ, and a vaginal hysterectomy is scheduled. So my question to you is, what would be an appropriate surgical prophylaxis antimicrobial regimen for K.L.T? The selection of a prophylactic regimen should be based on the spectrum of activity of the agents and the most likely pathogens associated with the given surgical procedure, pharmacokinetic characteristics e.g., half-life, adverse event profile, impact on bacterial resistance selection, and cost. The usefulness of antimicrobial prophylaxis in vaginal hysterectomies is well established and should be directed against vaginal microflora, including gram-positive and gram-negative aerobes and anaerobes. The most effective, yet most narrow-spectrum agent should be selected considering that the goal of prophylaxis is not to eradicate every potential pathogen but to reduce bacterial counts below a critical level necessary to cause infection. Cefazolin has been proven to be as effective a prophylactic agent as ceftriaxone for vaginal hysterectomy. This finding reinforces the fact that a more broad-spectrum agent, e.g., a third-generation cephalosporin, is unwarranted. Similar to vaginal hysterectomy, cefazolin and numerous agents, cefoxitin, cefoxitin, ampicillin sulbactam, etc., decrease the incidence of postoperative surgical infection when the abdominal approach is used. As with vaginal hysterectomy, most trials have not revealed significant differences between first and second-generation cephalosporins. In contrast, Hemsel and colleagues observed a significantly higher incidence of major postoperative surgical infections in patients receiving the first-generation agent cefazolin when compared with the second-generation cephalosporin cefoxitin. Cefazolin exhibits a favorable toxicity profile and has a relatively long half-life, that is approximately 1.8 hours, and a single dose has proven prophylactic efficacy. Cefazolin also is considerably less expensive than broader-spectrum agents and is currently recommended by the American College of Obstetricians and Gynecologists. Although it has a broader spectrum of coverage, a single dose of cefoxitin would also be an appropriate choice for this patient. The next question reads, because cefoxitin has an increased spectrum of activity against the anaerobe Bacteroides fragilis, it is being considered as an alternative to cefazolin prophylaxis for K.L.T. I would like you to comment on the appropriateness of this proposed change in prophylaxis. The second and third generation cephalosporins and ampicillin sulbactam generally are not more effective than the first generation cephalosporins for surgical prophylaxis in vaginal hysterectomy or in gastroduodenal, biliary, and clean surgical procedures. One exception to these findings is in the prevention of infection after colorectal procedures and perhaps hysterectomy. Several investigations have documented the failure of first-generation agents when used as prophylaxis in colorectal procedures, probably a consequence of their weak anaerobic coverage. As stated previously, second- and third-generation agents and ampicillin sulbactam generally are no more efficacious than cefazolin and should not be used for surgical prophylaxis in most procedures. Cefoxitin, however, would be a reasonable choice in colorectal surgery or hysterectomy. Considering that this patient is having a hysterectomy, either cefazolin or cefoxitin is appropriate. The next question reads, S.N.L., a 57-year-old woman with rheumatoid arthritis and degenerative joint disease, has been admitted for total hip arthroplasty. She states that she had an anaphylactic reaction to penicillin in the past. My question to you is, how does this allergy history impact on the selection of surgical prophylaxis for S.N.L.? Cefazolin is the preferred prophylactic agent for most clean procedures, including cardiac, vascular, and orthopedic procedures. Although the risk of cefazolin cross-allergenicity to penicillin is relatively low, S.N.L. experienced a serious, accelerated reaction, that is hives, and shortness of breath, with penicillin. Consequently, she should not receive cefazolin. The organisms most likely to cause postoperative infection after total hip replacement are Staphylococcus aureus and Staphylococcus epidermidis. Nafcillin, cefazolin, and vancomycin possess excellent activity against Staphylococcus aureus, however, the beta-lactams have only marginal activity against Staphylococcus epidermidis. Regardless, nafcillin and cefazolin should be avoided because of the penicillin allergy, and the preferred agent for S.N.L. is vancomycin. Preoperative vancomycin dosed at 15 mg per kilogram should be administered IV slowly, during at least 60 minutes. This slow rate of infusion is necessary to reduce the risk of infusion-related hypotension. The next question reads, BKM, an 18-year-old woman, complains of severe acute abdominal pain and nausea. The pain is localized to the periumbilical region. BKM has a temperature of 39.5 degrees Celsius. After initial examination by her pediatrician, she is admitted to the hospital with presumed appendicitis, and an exploratory laparotomy is scheduled. What surgical antimicrobial prophylaxis should be ordered for BKM? As with colorectal surgery, the most likely infecting organisms in appendectomy are Bacteroides species and gram-negative enterics. On surgical inspection, if the appendix appears normal, that is not inflamed, without perforation, then antimicrobial prophylaxis is unnecessary. If the appendix is inflamed without perforation, a single preoperative antibiotic dose is necessary. If the appendix is perforated or gangrenous, that is complicated, infection is already established and postoperative treatment is warranted. The status of the appendix, however, cannot be determined before surgery. Therefore, all patients should receive at least one preoperative dose of an appropriate antibiotic. After surgical inspection of the appendix, the need for postoperative antibiotic therapy can be determined. Based on the pathogens likely to be encountered, an antimicrobial agent with both aerobic and anaerobic activity should be used. Consequently, cefoxitin is an acceptable choice for prophylaxis. The next question reads, on surgical exploration, BKM was found to have uncomplicated, that is non-perforated, or non-gangrenous, appendicitis. However, cefoxitin therapy was continued for 3 days. So my question to you is, what are the risks of indiscriminate use of antimicrobials for surgical prophylaxis? The risks of indiscriminate use of antimicrobials include the potential for adverse effects and superinfection. The administration of any beta-lactam agent poses the risk of a hypersensitivity reaction, and many antibiotics, including cefoxitin, as is being used in BKM, predispose patients to Clostridioides difficile-associated disease. The risk of developing this superinfection increases with duration of antibiotic exposure. Avoiding unnecessary initial and prolonged exposure reduces the risk of this superinfection and its associated complications. In addition, prolonged use of antimicrobials increases the selection of resistant organisms in a given patient that could be nosocomially spread to other hospitalized patients. The last two questions read, as the new infectious disease pharmacist of the institution, you are informed by the infection control team that antibiotic prophylaxis prescribed by the surgeons is not the same as what is indicated in the institution guidelines. Which criteria would you want to measure antibiotic prophylaxis prescription performance? What interventions could improve how antibiotics are used in prophylaxis? Antibiotic control strategies have improved the appropriate use of antimicrobial agents for surgical prophylaxis. Numerous factors including individual knowledge, attitudes, beliefs, and practice, team communication and allocation of responsibilities, and institutional support for promoting and monitoring practice influence antibiotic prophylaxis measures. Interventions for improvement are focused on education of practitioners, standardization of the ordering, the delivery and the administration processes, and providing feedback on performance as measured by infection rates and compliance with improvements. The Surgical Care Improvement Project, abbreviated as SCIP, a national multidisciplinary initiative developed by the Centers for Medicare and Medicaid Services, aims at improving surgical care. Reducing surgical site infections is among one of the targeted goals of this initiative. Prophylactic antimicrobial received within 1 hour before surgical incision, prophylactic antimicrobial consistent with published guidelines, and prophylactic antimicrobial discontinued within 24 hours of surgery end time are 3 performance measures included in this quality improvement process. The first 2, antibiotic timing of administration and appropriate antibiotic selection, are associated with a decrease in the surgical site infection rate. Smaller-scale projects have also been successful at improving antibiotic use and decreasing infection rates. A multidisciplinary team generated electronic quick orders allowing for a computer-enhanced decision-making process and developed an antibiotic administration protocol. Appropriate selection of antibiotics increased from 78% to 94%, timely administration improved from 51% to 98%, and clean wound infection rate decreased from 2.7% to 1.4%. In collaboration with other healthcare providers, pharmacists should be responsible for optimizing the timing, choice, and duration of antimicrobial surgical prophylaxis. Education of surgical, anesthesia, and nursing staff, supported by hospital policy changes initiated by pharmacists, improved appropriate timing from 68% to 97% and resulted in significant cost avoidance. Post-discharge surveillance is also critical in reducing surgical site infections. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 237.